where the experts meet. Online learning, practical and sweet. Every Saturday, 9 a.m. Central Time. YouTube, Facebook, X, and LinkedIn. Online.
Hey, good morning, everyone, and welcome to UroNurse. I'm your host, Vic Senese. Nice to have you on board. I do mean on board because I've been on a cruise all week, and today I just get off the cruise. But hey, if this is your first time checking us out, be sure to like and subscribe because we know how important that is. And today we're going to have a great episode for you. We're tackling one of the most important challenges facing healthcare professionals across every specialty: surgical site infections, or SSIs. These infections remain among the most common and preventable complications in healthcare today, impacting patient outcomes, recovery times, hospital costs, and quality of life. Joining us is infection prevention expert Dr. Melissa Forton, who will share the latest evidence-based strategies that clinicians can use to significantly reduce SSI risk and improve patient safety. And best part, this program has been approved for one contact hour. You just go over to our website. You'll be able to get on that website and click over to get the contact hour. Now, word of warning, I'm going to probably be up in the air, so I'm not sure if I'm going to be able to make the change on the website to get that contact hour up there. Thinking of ways I can do that, but if not, just give us a little time, because when I get back to my main studio, I'll go ahead and make those changes.
My name is Melissa Forton. I'm a nurse practitioner at the Norton Infectious Diseases Institute in Louisville, Kentucky. And today I want to talk about surgical site infection prevention, things that we can do before surgery, during surgery, and after surgery to help prevent the risk of infection. Funding for this presentation was provided by the Kentucky Department for Public Health. There was no commercial support, and I have nothing to disclose. By the end of the presentation, I would expect you to be able to identify and explain the risk factors that increase the likelihood of a surgical site infection, identify modifiable and non-modifiable risk factors, describe the different types of surgical site infections, and describe interventions that reduce the risk of a surgical site infection. So surgical site infections are one of the most common and the most costly healthcare-associated infections. It's determined that 1% to 3% of patients who undergo an inpatient surgery will develop a surgical site infection. And people that do develop these infections have a 2 to 11 times higher risk of death, not counting increased use of antibiotics or other antimicrobials, extended hospital stays, loss of income, the cost to both the patient family and the hospital. And it also has been determined that up to 60% of these infections can be prevented if we use evidence-based guidelines. Now, let's review just very quickly wound healing or incision healing. Now, this is what we would expect if someone's perfectly healthy and they have no problems. This is what we would expect to happen. And this can get really complicated and really complex, but this is just a very brief overview. So the first thing that will happen is that we're going to have increased blood flow to this wound or this incision. And that's going to help bring platelets to the area and will help stop any bleeding. It's also going to release some growth factors. Now, the next thing that will happen is our inflammatory response. And I think, when we hear inflammation, we often think of this is a bad thing. But inflammation is actually a really important part of our immune system response to infection or threats of infection, and it's an important part of healing. So sometimes this inflammation can cause discomfort, but it is an important aspect that we have to respect. So during this inflammation stage, again, we're going to have increased blood flow, and that's going to help bring lots of nutrients and oxygen to this area. And it's also going to bring a lot of cells, specifically from, the immune cells. So we're going to have cells that are able to identify any bacteria, if any bacteria got into this incision or this wound. They can quickly identify that, eat it up, and remove it before it has the chance to multiply and cause an infection. Also, our phagocytes, our macrocytes are going to be coming into this area we're going to have a lot of damaged cells and damaged tissue from the surgery. They will remove all of that. So it's going to kind of remove some cellular debris. As we get the proliferation stage, this is where we're going to start seeing rebuilding of the tissues, the cells, and the blood vessels. So we'll see angiogenesis, which again is the regeneration of some of those blood cells that have been destroyed during the surgery. We're going to have the extracellular matrix, which is kind of the scaffolding for all of these cells and tissues to build upon. And then our final stage is remodeling. And during the remodeling stage, the surface wound has been healed, the skin has closed, but there's still some stuff going on kind of below the surface. And that may go on for several months. We also have to think about the wound class. Now, this is something that's determined by the surgeon. So this is something the surgeon will determine. But here are the 4 types of wound class. So the clean wound is when we're doing a surgery, there's no infection, there's no inflammation, and the skin's typically closed. And it won't involve any sort of surgery on the GI, GU, respiratory, or genital tracts. And the infection risk here is less than 2%. So this is typically, we're going to have a surgery, there's no infection, but we're going in to do something. So this might be a joint replacement, thyroid removal, or hernia repair. Clean contaminated. So, I mentioned the GI, GU, respiratory, and genital tracts. Even if there's no contamination, there's no infection, any surgery that involves those tracts will be considered clean contaminated. Those will never be considered clean. So any entry into those tracts or where there's a low level of contamination. So these infection risk here is less than 10%. And so this might be a hysterectomy or tonsillectomy. Contaminated wound is one in which there is some sort of inflammation present. So this can be any sort of inflammation or infection, but there's no purulence, there's no pus. This can also happen when there's a breach in sterile technique or when there's any leakage from the GI tract. So if we're doing a surgery and there's some spillage from the bile duct or from the GI tract at all, that would be considered contaminated. Now, in this case, the infection risk does increase to 13 to 20%. And again, this could be any sort of surgery where there might be spillage from GI. And then a dirty or infected wound is one in which there absolutely is infection. There's purulence or pus, anything that's evidently infected. And this can also happen when there's inadequate treatment of traumatic wounds. So you might think of someone who's been in a really traumatic accident who has open wounds that have been, in the dirt. This would probably be a dirty or infected wound. Now, unfortunately, this is where we have our highest infection risk, and that's going to be about 40%. And examples, again, would be if there's a traumatic wound or if you have someone with chronic wounds that need to be debrided. And then types of wound closure. What we're going to see most of the time is primary healing. And that's where we've done the surgery, the wound is clean, and all the layers of the skin are closed with stitches, staples, glue, whatever. But this is what we're almost always going to see after a surgery. Secondary healing is when the deeper layers are closed, they're sewn up, but the top layers are left open. And the idea here is to heal from the inside out. And so this will require different type of care than a primary closure. But as you can see, because those top layers are open, there is a higher risk for infection. And then tertiary healing, we don't see very often. This is when we have a surgery, the wound is clean, the surgery is completed, but we don't close it. This wound is left open. And then it's observed. Sometimes these folks may go to the OR something like every other day so that this wound bed and everything can be examined. And they really won't close the skin until they're pretty sure that there's no infection and that things are starting to heal. So some examples would be like really jagged wounds or dog bites. I've seen this primarily in cases where there's an abdominal surgery, something like a perforated intestine or something where there was infection in the belly. and they will leave this open and then go in periodically, sometimes just once, sometimes more than once, to inspect the organs, to flush out the cavity with antiseptic solution, just to ensure that there's no developing infection before they close it. This is also, I've seen this in kids that had necrotizing fasciitis who needed to go to the OR every single day to have inspection and sometimes tissue removed. So again, we don't see it very often. These kids or patients are typically going to be in the ICU if they have these open wounds. And when we look at what causes these infections, most of the time it's an endogenous source. So this is a microorganism or germ from the patient's skin or from their, the organ that we're messing with. So it could be from our skin, the GI tract, the mucous membranes. It's almost always something on the patient's body, a germ that gets where we don't want it and causes an infection. Less often is an exogenous source. So this is where we get a microorganism or a germ from elsewhere, either during the surgery or after the surgery. So this can be if there's a contaminated instrument, a sterile instrument that becomes contaminated and it isn't recognized and they continue to use it, poor ventilation, if there's any sort of break in the septic technique. And then even more rare is a remote infection. So this is in the case where a patient has an infection in a different part of the body when they have surgery, and those germs, those microorganisms from that infection are able to get over and infect the surgical site as well. And so you can see when we talk about reducing the risk, we're looking at a lot of this. How do we reduce these sources? So when we look at the most common pathogens, and this is from 2014, the most common pathogens that we saw in surgical site infections: Staph aureus, E. coli, coag negative staph, Enterococcus pseudomonas, and Bacteroides. So you can just look at the pathogens, that most of these pathogens are ones that live on our skin or in our GI tract. And when we talk about wound classification, and we'll talk about this a little bit more later, our superficial incisional infections are the ones that are going to be most superficial. It's going to be the skin and maybe some subcutaneous tissue. And of course, because it's superficial, it typically is going to be the easiest to treat. The deep incisional infection will include the fascia and muscle. And then the most difficult to treat are the organ space infections, which are actually, further down there in the area where we have manipulated during surgery. So when we think about the risk factors for a patient, anytime a surgeon is examining a patient or discussing surgery, they're going to be looking at the risk factors. What is the risk that this person will develop an infection? And we often put these in two categories: modifiable and non-modifiable. And you'll see that I have some italicized because I don't know that they always fit in the category in which they're placed. So something non-modifiable is someone's age. We know that older people tend to have a less robust immune response to infection, but we can't change someone's age. We can't make them younger. If a patient had recent radiotherapy to the site where we're going to do the surgery or close to that area, we can't change that. Now, when it comes to infection, this can sometimes be modifiable. Sometimes a patient has an infection, and that's why they're getting surgery, or it's not going to get better until we do surgery. And in those cases, we can't change it. We have to do the surgery. But there are, I mentioned that one of the causes for a surgical site infection is a remote infection that the patient has. Patients will be screened to make sure they don't have any other sort of infection going on. Let's say a patient's having a knee replacement surgery. If they developed the week before that, they develop a cough and fever, that's a risk for surgical site infection for that knee. So often the orthopedic surgeon will cancel the surgery and move it a little further out to allow that patient time to clear whatever respiratory infection they have. So sometimes this infection is modifiable, sometimes not. When we think about things that we can potentially influence and change, obesity. Obesity is considered a BMI of 30 or greater. Sometimes we can influence this. People that are a current smoker. So current means I smoke or I have quit in less than a month ago. Having an albumin of less than 3.5, a normal albumin is 2.5 to 5.0. So having a low albumin is a risk factor. Poorly controlled diabetes or hyperglycemia can potentially be modified. We can't change the fact that someone has diabetes, but we can potentially help them control that better before surgery if they have poorly controlled glucoses. And then immunosuppression, again, sometimes this is modifiable, not always. It really depends on what type of immunosuppression and the cause, like the need for, like what the diagnosis is. So if a patient has cancer and is receiving chemotherapy, for example, sometimes they can pause chemotherapy for a period of time to allow that patient to have surgery and recover. People that are taking an immunosuppressive medication for something like an autoimmune disease, sometimes that can be paused, again, depending on what it's being treated, and sometimes it can't. So it really will depend on the medication being used and why it's being used. So why is smoking a risk factor? People that are current smokers, so again, people that are smoking or have quit in less than 30 days, have the highest risk of surgical site infection, regardless of the surgery type. Now, smoking by itself, without even considering surgery, it causes vasoconstriction. So it causes these blood vessels to constrict or to tighten, and it will decrease blood flow. Now, during surgery or after surgery, this is going to decrease blood flow to that surgical site. So then we're going to have poorer perfusion. We're not going to get the delivery of nutrients and oxygen the way we want. Smoking diminishes the function of white blood cells and interferes with the immune system's ability to recognize bacteria. This is the opposite of what we want. We want those white blood cells to recognize bacteria and get rid of them right away before infection can develop. Smoking also reduces fibroblast formation, so it can interfere with clotting. Now, this study looked at patients who were going to have either a hip or knee replacement. These were all smokers, and the intervention group agreed to stop smoking 6 to 8 weeks before surgery. The control group continued to smoke. The folks who had elected to quit smoking were offered weekly support if they needed it to help manage their cravings and to continue to reinforce the risks of infection if they continued to smoke. They looked afterwards, and you can see just a really stark difference between the non-smoking group and the current smoker group. So 31% of the folks who continued to smoke had some sort of wound-related complication, while 5% of the folks who quit smoking did. 23% of the smokers had an infection, while 4% of those who quit smoking did. 8% of the smokers had a subfascial involvement, and 15% required additional surgery. For the folks who quit smoking, 2% had subfascial involvement and 4% required a secondary surgery. So you can see very, very stark difference here. Diabetes, having elevated glucose will lead to reduced tissue oxygenation. So we're not getting that great oxygenation to those tissues and to that incision site. And that will reduce the white blood cells at that incision site, again, which is, we want those white blood cells there. It can lead to a prolonged inflammation, reduced levels of growth factor, which we really need for that healing process. And it can cause some dysfunction of angiogenesis when we have those new blood vessels forming. So lots of problems with healing when we have diabetes. And when we think about diabetes as a whole, we know that folks that have wounds, especially on the lower extremities, tend to have a longer or more difficult time healing. So this does carry over to any sort of intentional wound, i.e. surgery or incisions. Now, this study looked at folks who had a single level lumbar decompression surgery, who also happened to have an A1C in their in their records. And they looked at the risk of infection and the A1C. And as you can see kind of on the scale here on the left, that once the A1C hit about 7.5, there was an increased risk of infection. That line on the left tells us the infection rates there. And these were folks that were followed for 1 year after their surgery. The higher the A1C, the higher the risk of infection. Now, there have been some conflicting studies regarding A1C as the measure. And it's really been determined that glucose control around the time of surgery is more important than the A1C. A1C is a blood test that measures kind of the average glucose over the previous 3 months. So a patient could have a really great A1C from 2 months ago, but most recently have not been following the recommendations regarding diet medication. So they may go into surgery. We may have this false sense that they're taking that their glucose is well controlled when it may not be. And vice versa. We could have a patient who had an A1C that was really high 2 months ago, but has been really following all the recommendations, and their glucose control has been really stellar around the surgery. This may lead to someone wanting to delay surgery because the A1C, is not ideal, without really paying attention to what the control is like now. There is a blood test that is becoming a little more popular to use called fructosamine. It may be a little bit better at assessing how the glucose control is going now. This measures the average glucose over 2 to 3 weeks. So it may give us a better idea. There also are cases, of course, where people come in and they just need to have surgery and there's not a chance to examine A1C. So it's just really, really important that we control glucose around and following that surgery. Now, obesity just impairs the immune system. There are proteins and hormones that are released by fat cells that have profound effects on the immune system. So they can affect both the innate immune system and the adaptive immune system. Obesity does cause an increase in circulating inflammatory proteins. When we have that inflammatory process, which I said is so important, the body has ways of initiating that inflammatory process, and it has ways of stopping it or slowing it down as people improve and their infections improve. And so what happens with obesity is that obesity is really good at initiating inflammatory responses, but it's not very good. It really interferes with the stopping of the inflammatory process. So unfortunately, with obesity, what we have is people that kind of end up in a persistent inflammatory state. Obesity also reduces B and T cell proliferation, which these are really important parts of our adaptive immune system, and it can cause some endothelial dysfunction, which of course we don't want. Now, depending on the obesity and depending on the incision site, it potentially can cause some tension. And persistent tension on an incision site will increase the risk of dehiscence. It'll increase the risk that incision opens up. And then, of course, if it's open, it's going to have a higher risk of infection. Now, this study looked at patients patients and surgical site infections after colorectal surgeries. And they were comparing patients who had a BMI of below 30 and over 30. And this was a meta-analysis. And you can see on the right here, looking at the odds ratio, that vertical line is 1, basically meaning that there's no difference at all. And except for one study, you can see that all of these studies showed that there was an increased risk of surgical site infection for patients who had a BMI of over 30. And you can find a lot of studies looking at weight and obesity. Sometimes they will compare above and below 25, a BMI above and below 35. But across the board, obesity is associated with increased risk of surgical site infections. Now, albumin is our plasma protein, is the most abundant one we have in our blood. And it's a really easy, quick way that we can take blood and kind of it'll give us an indication of the patient's nutrition. Albumin itself has robust anti-inflammatory properties, and it provides protein that's essential for wound healing. When we have albumin below 3.5 or that low albumin, what happens is we'll have prolonged inflammation because albumin's not there to kind of to do its kind of anti-inflammatory job. And it will really inhibit the production of collagen and proteoglycan, which are needed in wound healing. This was a meta-analysis, and they were looking at albumin less than 3.5 in surgical site infections after orthopedic surgery. And again, if you look at that vertical line, all except for one, which is on the left, have an increased risk of surgical site infection for people whose albumin was less than 3.5. And it looks like it's about 2.5 times more likely, patients 2.5 times more likely to have a surgical site infection if the albumin is less than 3.5. Now, the guidelines really identify having a low albumin as a risk, but it's also very clear that they don't want to delay surgery if the albumin is lower than we'd expect. And I wanted to throw in a slide here about enhanced recovery after surgery, or ERIS. Now, this is using a bunch of different evidence-based protocols, and it's for surgery kind of before, during, and after, with the idea that they want to help patients kind of get back to themselves more quickly after surgery, want them to be recovered more quickly and be discharged back home more quickly. It does discuss nutrition. So they do recommend that patients that are going to have surgery have some sort of nutritional evaluation. And if they have an albumin that's low or they have some malnutrition, they do recommend oral supplementation a week to 10 days prior to surgery. And the oral supplementation is just the over-the-counter nutrition drinks that there's many brand names that people can use. Now, again, it shouldn't be delayed. We shouldn't delay the surgery if the patient needs surgery. But if it's going to be a surgery in a couple of weeks, this is a great time to kind of beef up that nutrition before they go to the OR. ERIS also recommends a shorter NPO window. We know that a lot of people just are told don't eat or drink after midnight, when that's not necessarily necessary. So they recommend 6 hours of NPO prior to surgery, but allowing clear fluids up to 2 hours before the surgery. So this is a shorter NPO window. It's going to keep that patient hydrated, more nutritionally sound. And they do recommend that a normal diet is introduced early in that postoperative period. They do prefer that people are offered food and drinks as appropriate after surgery instead of waiting a predetermined amount of time before offering you that food. So prior to surgery, some of those interventions would be that ensuring the glucose is well controlled, encouraging that patients quit smoking within 30 days of surgery. And the American College of Surgeons really encourages the use of cessation aids if necessary. So they recommend that if a patient is really struggling with the smoking cessation, to use a patch or to use nicotine lozenges or nicotine gum. Again, we want to avoid any immunosuppressive medications if possible. Well, nasal decolonization prior to surgery, they do recommend that we don't clip hair unless it's necessary. If so, we clip it and we don't shave with a razor. And then identify and treat any other infections that patient may have. And I wanted to point out that the surgery team has the right to refuse to do surgery on anyone that they feel is at high risk. There are some surgical groups who will not do surgery on a person who smokes. There are people who will not do surgery if the BMI is higher than some predetermined number. However, even if you are in a facility or you're part of a surgical group that has those rules, the surgeon has to use discretion. If they have a patient who has a lot of pain from a joint, for example, that needs to be replaced, and the patient's overweight, they may not get their BMI as low as the surgeon would like until they have surgery, because the pain is too great for them to go out and do the physical activity they need to lose weight. So again, this will always be the surgeon's discretion. Ideally, we would only want to take the healthiest people with the best immune system to the OR, but that's just not reality. Now, I mentioned nasal decolonization. So a lot of folks have staph on their skin. This is just one of the normal bugs that we have on our skin. But about 1 to 3% of people are colonized with MRSA, which is an antibiotic resistant strain. And most of the time, this colonization is in the mouth or throat, in the nose. And having an infection with MRSA can cause really, really poor outcomes. And the mortality rate can be up to 20%. Now, if you are colonized with Staph aureus, this increases your risk of having a Staph aureus infection by up to 9.6 times. Now, the nasal decolonization, it varies a little bit, but typically the most common protocol we're going to do is applying 2% mupirocin into each nair twice a day for 5 days prior to surgery. Again, there are some other protocols, but this is the most common one. Now, skin decolonization, again, our skin contains, lots of different germs. That's just part of our biome. And some of these, they typically aren't causing us any trouble, but they could. So anytime we have surgery, then we're offering this pathway for these germs to enter. So skin colonization will kind of reduce the burden of germs. We can't sterilize the skin, but this will help reduce the number of bacteria and other germs on our skin. And this typically takes place at home, usually with wipes that look kind of like diaper wipes, with 4% chlorhexidine gluconate. This again can also come in a bottle of liquid. And there are folks who may not have access to chlorhexidine, perhaps a price. Oftentimes this is given to the patient by the surgical team. But if it isn't, patients can use an antibacterial soap. Now, within the operating room, so when we get to the OR, what do we do to reduce the risk of infection? Well, we make sure that all the folks in the OR have done an appropriate hand scrub. There's a skin prep. This is different than skin decolonization. And this is when there's a very deliberate cleaning of the area where the surgery will take place with an appropriate cleanser. We want to make sure that we're giving any antimicrobial prophylaxis if it's indicated. We want to avoid blood transfusions. The surgical team will do everything they can to maintain homeostasis, but they don't want to do blood transfusions if they don't have to. They certainly will if that's required, but we want to avoid it. We want to make sure that everything remains sterile in the OR. The staff have appropriate gloving. We want to minimize the surgical time, minimize traffic in and out of the OR, and try to keep that patient's body temperature normal. Now, blood transfusion, not related specifically to surgery, but just any blood transfusion causes something called TRIM, a transfusion-related immune modulation. So anytime a person gets a blood transfusion, it's going to increase the number of suppressor cells, decrease the function of natural killer cells, and the function of macrophages and monocytes. So this is a temporary suppression of the immune system anytime you get a blood transfusion. That's why we want to avoid it if we can. Now, this study on the right here looked at blood transfusions and surgical site infections in pediatric patients who had either general surgery or thoracic surgery. And you can easily see that those who did receive a transfusion were significantly more likely to have surgical site infections of all kinds, superficial, deep, organ space, dehiscence. So having that transfusion really increases the risk of having an infection. Prophylactic antibiotics are typically given within 60 minutes prior to the incision. And these are sometimes will be continued up to 24 hours. If there's a surgery that's taking a really long time or there's a lot of blood loss, then you may need to give additional doses. Our idea here is that we want this antibiotic circulating in the blood when that incision takes place. So again, 60 minutes, within that 60 minutes prior to the incision. Now, there are a couple of medications that have a longer infusion time. And for those few medications, the antibiotic can be given up to 120 minutes prior, but typically within that hour. The most common prophylactic antibiotic given is cefazolin. Now, the antibiotic choice that will be determined by the type of surgery, the anatomy, the risk factors, what potential bacteria or germs might we encounter. But again, cefazolin is the most common. Now, people that report a beta-lactam allergy or a penicillin allergy won't be able to get cefazolin. They'll have to get a secondary or alternative antibiotic. And that's going to increase their risk of developing a surgical site infection by 50%. So we always want to use the prophylactic antibiotic that is the best choice for preventing infection. So if we do have a patient that reports a beta-lactam allergy or penicillin allergy, we have to do a really thorough history of this allergy and make sure this is documented. And that will include exactly what antibiotic did you take, what was the reaction, what did it occur right away, when did it occur? Did it occur several days later? Did it occur half an hour after you took the medication? Have you taken this medication since then? Because we always want to give cefazolin if that is the most appropriate. Normothermia is typically considered a temperature of at least 36 degrees Celsius or 96.8. When we have a temperature below that, this can be caused by having exposed skin. We know that when we go to the OR, we're not typically fully clothed. Fluids that are cool can decrease our temperature. And then just anesthesia by itself can reduce the brain's ability to maintain body temperature. And so anytime we're cold like this, we're going to have vasoconstriction. So we're going to have reduced blood flow. So that's reduced blood flow to the incision site or the surgery site. We're decreasing, oxygenation to that area, and we're decreasing any circulating antibiotic to that area as well. Being cold also impairs the immune function. So what we'd like to do is keep that patient their temperature at least 36 degrees Celsius. And we could do that in a couple of different ways by keeping patients covered, having warm blankets, making sure IV fluids are warmed. There's sometimes some forced warming air as well that can keep this patient warm. Now, in the OR, I mentioned there's skin prep in the OR. And again, this is to reduce the pathogens at and near the incision site. Now, most of the time, this disinfectant is going to come in a pre-filled applicator stick, and like in the photograph. The staff member whose job it is to clean will begin cleaning at the incision site using back and forth motions, and then they'll slowly proceed to the periphery, and they'll allow that solution to dry completely. So this is just a very methodical, thorough cleaning of the skin. Now, the staff should follow the manufacturer's instructions for use. Those times and instructions are slightly different on some of the products. And then the surgical hand scrub. So we can do this with water-based or waterless. This is going to happen before going into the OR. It will always start with the staff member cleaning their hands with soap and water like they typically would if they were just going to clean their hands, clean under the nails, and they're going to remove any jewelry from the wrist, from the elbow down. So watches, bracelets, rings, all of that will be removed. Now, so this example shows us a 5-minute scrub. There are some hand scrubs that are longer. So if you have a 5-minute scrub, it looks like this. The sponge will contain a cleanser like chlorhexidine. And you can see there's, again, a very methodical scrubbing of the hands, the fingers, and the forearms. And the staff member will need to make sure that they keep their fingers and their hands above their elbows the whole time. We want any water that's dripping to drip from the elbows, not from the hands. Now, the hand scrub where we use a waterless is a little bit different. Now, this is not someone using the typical antibacterial like hand scrub that we have throughout the hospital and throughout stores and things like that. This is a specific type of antiseptic. And this was a little different than the hand scrub, the water hand scrub. This one actually will involve the staff member cleaning their fingertips and under and around their nails first, then cleaning from the wrist to the elbow, repeating that on the other hand. And the final step is actually going to be scrubbing the fingers, the hands, and the backs of the hands. Once this is completed, the staff member will wait for this to dry completely before they put on any gown or gloves. When it comes to the duration of the surgery in the OR, we know that the longer the patient is in the OR, the higher the risk of infection. So on the left here, we have looking at some folks who had a knee replacement. They determined that most of the surgeries lasted about 106 minutes. So they kind of looked at this, and we can see that once the duration of the surgery hits about maybe 90 minutes, the risk of infection increases. So, and this is really looking at deep infection. So the longer the surgery, after about 95, 100 minutes, the risk of infection increased. On the right-hand side, they were looking at how long the surgery lasted and the risk of infection. This was a systematic review that had lots and lots of good information, and it included all kinds of surgery. So neuro, cardiac, GI, ortho, like all the kinds of surgeries. It has a lot of information if you want to read that. But really, they found that the longer the operating time, again, the higher the risk. So for every 15 minutes, there was a 13% increase in infection. Now, post-operative management, we want to make sure that, again, that glucose is well controlled, the patient has adequate nutrition, appropriate wound care. If they're inpatient, we want to make sure the linen and gowns changed every day. And again, daily chlorhexidine bathing is recommended in some cases. We look at glucose control. These were some studies that looked at glucose after surgery and the risk of SSI. On the left, these were folks that had GI surgery. The range of glucose is on the bottom, and on the left was the infection rate. And as you can see, the lowest infection rate was for those folks who had glucose of less than 110. And as the glucose increased, the rate of infection increased. On the right, this was glucose that was after general or vascular surgery. And you can see there, they looked at A1C, glucose, and there was this pre and post-op. And you can see this was, they primarily looked at the glucose under 140, and then 140 to 180, and then over 180. And as that glucose increased, the surgical site infection rate increased. They also looked at the A1C, and again, less than 7, there was an 8.43% risk of infection. If it was over 7, then the surgical site infection risk had doubled. Different groups, different facilities will have different ranges of acceptable glucose control. Sometimes this will be under 180 after surgery. Sometimes it's less than 200. So it may differ from facility or from surgery group, but the idea there is that we want to have that glucose pretty well controlled after surgery. Now, wound and incision care will vary depending on the type of surgery, how it was closed, the risk factors, and things like that. So it's very important that we have specific recommendations for the wound care for each patient. In general, the instructions will be to change the dressing only when necessary, that we don't immerse this in water, so we don't go swimming or bathing. Depending on the surgery, some folks may be able to shower the next day. Sometimes they may want the patient to wait 1 or 2 days. We typically don't have patients put any ointments or creams on the incision site unless they have been instructed to. We want to really make sure that patients understand how to care for that wound, that they need to have really good hand hygiene before touching the wound or changing the dressing. not to pick at any scabs, and to make sure that they have all the necessary supplies to take care of their wound appropriately. When patients have a planned surgery, a lot of this education can begin before the patient ever goes to the OR, getting supplies, making sure that the patient or a family member knows how to manage this incision. Unfortunately, often people come to the hospital and they have to have surgery right away, or they may come to the hospital, perhaps to have a baby, and then unfortunately require a C-section. So they don't have any expectation that they're going to have this wound they need to manage. So it's important that we provide them with all of the education that we can. Also, are they going to have the supplies? Sometimes these supplies are costly. Sometimes they're not covered by insurance. So it's important that we make sure that they have what they need before they leave, or we know that they have the access to it. We don't want the situation where a patient or family leaves the hospital and they don't pick up the supplies because it's too expensive. Now, I mentioned how important it is that we talk with patients about how to care for their wounds and about infections. And I just thought this was a really interesting study that was done in Brazil. And these were folks who had surgery, were admitted to the surgical ward, and it included the nurses and the doctors that were involved in the care of the patients after their surgery. And they really talked about the perceptions from the patient's perspective, the nurse, and the physicians. Now, most of the patients and the professionals, the nurses and doctors, agreed that it was important for the patients to be involved in infection prevention. Now, there were some differences of agreement noted between men versus women. So men were a little less likely to agree that it was important for them to be involved versus women. And then education level also played a factor. So those with the highest education levels agreed the most strongly that it was important for the patient to be involved. Those with the lowest education level did not feel it was as important. But you can see that, I think this is interesting, that you can see what the patients preferred and what practitioners preferred. So right away, we see that about 75% of the doctors and nurses felt that an oral presentation or an oral discussion with the family was the most effective way to educate, while only about 47% of the patients felt that was the case. It looks like on here, as healthcare workers, what we felt was most effective doesn't necessarily match with what the patients felt was the best. And even looking at the discharge follow-up, you can see that 66% of doctors and nurses preferred the patient come to an outpatient follow-up, while the majority of patients preferred to have some sort of a text message or a video call. Again, not at all what the healthcare professionals thought. So I think that's also stresses how important it is that when we begin educating people, that we make sure we know what their preferred method of learning and their preferred method of communication is. Now, fortunately, in the US, we often have a couple of different options. We usually have, discussion with the patients. So we often have handouts and video sites that they can look at as well. But it's just really important it really highlights the importance of communicating with the patient and family about how they want to be involved. Now, one of the best things that we can do in a facility is to use surgical site infection bundles. Now, we use bundles for lots and lots of different things. A bundle is really a collection of evidence-based practices, and we can tailor it to specific surgeries or facility types. So we may have an SSI bundle for hysterectomies. We may have one for a knee replacement. We may have one for different cardiac surgeries. Now, we use these a lot when we have bundles for preventing catheter-associated urinary tract infections or bloodstream infections. We use them a lot. And they work best when we get an interdisciplinary group together. So when we look at surgical site infections, having some folks from surgery, from anesthesia, people that work in the OR, pre and post-op. If these are patients who typically require inpatient stay, having some of those staff that care for them inpatient. is helpful to be involved. We can come together and find out what works best. And so these are going to consist of interventions that this group will follow to reduce the risk of surgical site infection. Now, there can be a whole long list, but the idea of a bundle is that we don't get it too long. And it's not set in stone. It may change if we get more evidence, or there's something that changes, a new product, things like that. And it's going to be different from hospital to hospital or facility to facility. It's not going to be the same everywhere. Now, it's important, though, when we develop a bundle, and we have maybe 7 things on there that we want to do, it's important that we monitor this and we perform audits and see how often those are being followed. So if one of our bundle components may be that the patient has a BMI less than 40, 95% of the time, we need to see, are we following that? If we have a bundle that includes for knee surgery that we're going to give this prophylactic antibiotic within 60 minutes before the incision, we want to use 100% of the time. How often are we doing that? And we can also then follow up, why didn't we do it? Was there a reason? And we can intervene. And again, these are gonna vary. And it's important that once we have this information, that once we do these audits, that we're giving feedback to all the folks that are involved. Now, an example, this is the American Society of Colon and Rectal Surgeons. This was their SSI prevention guidelines from 2024. And for some of their recommendations were that that staff use both oral antibiotics and mechanical bowel prep for people that are going to undergo colon resection. That hair removal should be done by staff with clippers. Those antibiotics given within 60 minutes before the incision. That for most of the time, they're going to limit those antibiotics for 24 hours. That the surgical site needs to be cleaned with chlorhexidine alcohol-based solution. The use of impervious plastic wound protector for open belly surgeries. Using minimally invasive techniques when available, and using negative pressure wound therapy when appropriate. So these are fantastic. This is kind of like the baseline, the backbone of some of the things that need to be done by these particular surgeons to reduce the risk of infection. A facility may include some of these, it may include some other things. Maybe they're always fantastic about giving the antibiotics. So they want to focus on something else, maybe that they're not quite as good at. Now this was done back in 2006. So this is an old study, but this was looking at a facility that had a 26% incidence rates of surgical site infections after elective colonic resection. So in this case, this is a pretty high rate of infections. They developed a bundle, and it included many things, but it included, again, giving that antibiotic before the incision, continuing it for 24 hours or less afterwards, maintaining that normothermia, keeping the glucose less than 200 for at least 48 hours, and placing a Penrose drain for patients who had a BMI over 25. So once they implemented this bundle, the compliance rate increased. So all of these elements, I guess, were things that you're having trouble ensuring was happening. So we had an increase in compliance, an increased number of patients who were getting this appropriate care. And the surgical site infection rate fell to 15.9%. So it was 26%. So while 15.9 seems really high, that's a pretty good improvement. And I'm sure that since then they've likely done even more. The American College of Obstetrics and Gynecology, or ACOG, had some SSI prevention guidelines in 2018, and you'll see that some of these are very similar. Again, using clippers if necessary to remove hair, keeping that glucose less than 200. The patients should use chlorhexidine skin wipes the night before and the morning of the surgery. That skin prep in the OR be done with chlorhexidine alcohol. For patients that are having a hysterectomy or any sort of vaginal surgery, that they use a 4% chlorhexidine gluconate or povidone iodine intravaginally prior to the surgery. And they also recommended that any antimicrobials be weight-based, and also, of course, given within 60 minutes of the incision. Now, the facility has also, of course, an important role in that prevention. So we want to make sure that our policies and practices reflect the most current evidence-based guidelines, making sure that staff have this education when they're hired, that it's reinforced at least annually, or again, when there's a new protocol or a new product. We want to make sure we have that surveillance. And we want to have an adherence monitoring program too. So we want to be able to make sure that folks are doing hand hygiene appropriately, that the sterilization of reusable devices is being done appropriately. Maybe going to the OR to just observe and make sure that all of those parts of our bundle are being met. And again, providing feedback. Now, any healthcare facility, any acute care facility that participates in CMS's hospital inpatient quality reporting and promoting interoperability program has to submit surgical site infection information. This is called NHSN, National Health something. I can't remember this. Now, currently, we're only required to report on hysterectomies and colon surgeries. But many facilities also submit information about their other surgeries as well. Now, I mentioned that this is something that we have to report, but facilities should really be monitoring this for their own use as well. National Health Safety Network, that's what it stands for, NHSN. So this is kind of the denominator form. So this is filled out for every single procedure that meets the definition. Now, this is done online, but this is kind of a printout, if you will, of what information is submitted. So if I am submitting information about hysterectomies, I'm going to fill this out, and it's going to be submitted every month for every patient in the facility who undergoes a hysterectomy. And you can see it includes the patient, some demographic information, ICD-9 codes. Was this patient inpatient or outpatient? What was the wound class, height, weight, how long the surgery lasted, was there general anesthesia, how was this closed? Just kind of some basic information. In addition, we're going to submit a numerator form, and this is for every month. Again, this is going to be for the patients who develop a surgical site infection. And you can see that this information is a little different. We again are going to have some patient-specific information at the top. We're going to be filling out what kind of infection this was. Was it superficial? Was it an organ space? Was the infection present at the time of surgery? And then which signs and symptoms did the patient have? If we had a laboratory, like a culture, we'll click that we had that, and then there'll be some information about what pathogen was found and was it antibiotic resistant. Now, it's important to remember that this is patients who meet the surveillance definitions, not necessarily the clinical definition. There will be some information that is developed that's risk adjusted, and it'll give facilities the number of expected infections versus the number of actual infections. Now, this can get a little bit complicated. I'm not going to go into it because this is really something that infection preventionists work with, but there's lots of information about, what constitutes a superficial incisional SSI, for example. And so I want to go through some of what the definitions are. So for a superficial incisional SSI, remember this is our most superficial. These are infections that occur within 30 days after that surgical procedure, and they meet one of these 4 criteria. So purulent drainage or pus, an organism that's been identified from a culture, a diagnosis of the superficial SSI by the physician with at least one of the following: pain, tenderness, swelling, erythema, or heat, or the incision was opened up by the surgical team and a culture was either positive or not cultured. For a deep incisional SSI, again, this is going to occur within 30 days after the surgery. There are a specific list of surgical surgeries that will be monitored for 90 days. So that's why I have that little star there. Typically 30 days, but there are a few that will watch for 90 days. This will include infection of the deep, soft tissues of the incision and have to meet at least one of those 3 criteria. So I have that there. I won't read it aloud. And then, of course, these the organ space SSI again within 30 days, except for those specific surgeries that we watch for 90 days. And it has to meet at least one of those three criteria and the surveillance definition for a specific NHS and infection site. Now, take-home points, of course, are that most surgical site infections can be prevented by following evidence-based guidelines. Patient-dependent risk factors should be identified and mitigated prior to surgery if possible. And the use of SSI bundles may decrease the rates of surgical site infections. I want to thank you so much for joining me today.
Next week on UroNurse, I tackle one of the most common and most misunderstood conditions in healthcare today: urinary tract infections. Join me as I explore the latest 2026 updates in UTI diagnosis, treatment, prevention, antibiotic stewardship, recurrent infections, advanced urine testing, and emerging technologies changing patient care. Whether you work in urology, primary care, long-term care, or simply want the latest evidence-based insights, this is an episode you won't want to miss. Join us on June 20th at 9 a.m. Central Time to learn more.
So here's to the mornings, the coffee, the monitor glow, to the wisdom he shares and the folks that he knows. Saturday's special when Vic's on the stream with 40 years of knowledge and a head full of dreams.